Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President and CEO of Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. My colleagues and I invite you to join us at these gatherings each month as we explore critical issues shaping American healthcare. The Centers for Medicare and Medicaid Services, known of course as CMS, is advancing toward their second round of price negotiations with pharmaceutical manufacturers. This first round of negotiations focused on lowering the prices of 10 high-cost drugs. The second round will include 15 additional drugs and will be announced in February of next year. Joining us today are two experts on this negotiation process and how it could impact our healthcare system. They are John O'Brien, President of the National Pharmaceutical Council, and Jason Spangler, Chief Executive Officer of the Center for Innovation and Value Research. Welcome to both of you and to everyone in our audience. As we begin our discussion, can each of you give us some brief background on the focus of your organization and your role in it? Let's start with you, John.
Well, thanks, Jim. It's great to be with you and Jason. And of course, it's always great to be back in front of the Northern Virginia Health Policy Forum. I'm John O'Brien. I'm the President and CEO of the National Pharmaceutical Council. We're a 70-year-old health policy research organization based here in DC. I'm a pharmacist by training, but some people know me from my time in government service. But I've actually spent my whole career working around the healthcare system. And that helps me see and better understand the impact of a system that views prescription medicines as an arbitrage opportunity, something to extract margin from, as opposed to something that's really important to caring for patients, because prescription drugs help patients get well and stay healthy and avoid higher healthcare cost settings. Today, I'm really excited to be at NPC because we do policy-relevant research and share it with important stakeholders like your audience who are advocating for better health and patient access to innovative medicine. So thanks again for having me, and I'm really looking forward to the discussion.
Thanks, John. Jason, can you tell us more about the center?
Thanks, Jim, and it's great to join you and John again, and just to reiterate what John says, it's great to be in front of your audience. So I'm Jason Spangler. I'm the President and CEO of the Center for Innovation and Value Research. We are a nonprofit research organization that focuses on how we can do a better job of determining value of new innovations and technologies in healthcare, mainly from more of a patient-centered and equitable perspective. So we do that with some research, kind of health economics research, as well as kind of larger projects and initiatives trying to understand more about patient preferences and what patients value and how we can calculate that within how we assess the value of these new innovations, particularly drugs, but also other new innovations as well. Regarding what John had said about what NPC does, we partner a lot with his organization as well. We do complementary work, I would say. And with regard to negotiations, I think we're all concerned about making this process even better, looking at from more of the patient perspective and making sure that any unintended consequences are minimal.
Great. Thanks, Jason. And you both have been following the price negotiation program very closely. Not all of us have been following it as closely as both of you have. So for our audience, could you level set and give an overview of what is this price negotiation program and where did it come from and what happened in the first round?
I'll go first, John, and then you can add on. I mean, drug pricing has been a particularly important political issue, I would say, for many, many years. And ever since the implementation of the Part B benefit, there were those who were kind of opposed to the original structure of that and wanted to have the government have a larger role in determining what those prices are and not leave them to the private payers that were doing those negotiations. And I think many felt that the government would be able to bring prices down even further because of their how large they are and the leverage they would have with the manufacturers. And so I think after many years, we're now almost 20 years after the implementation of the the Part D benefit, we'll have some sort of negotiations. I think we could probably argue what that term means, because it's different, I think, for the manufacturers than it is for the government. But they wanted to, I think some of the compromises wanting to start slower and with less drugs that have already been in the market for a while. And so, the first 10 drugs that, we just found out what they were last year, and then what the prices, or the MFP, or the maximum, fair price would be for those, was just determined, over the past year. The one thing I would say, or we just found out about, what I would say, what we've learned that the first negotiations is that this is a very fluid process. CMS had a very limited amount of time to implement the legislation. They have acknowledged that there's a lot of things that they might get wrong, and they want to try to get as much right as possible. They're adhering pretty strictly to the statute. They're not wanting to go very far off from what they feel like is, what they've been told to do in the legislation. But they've also, like I've said, they've acknowledged that there's areas where they will try to improve in subsequent years. One of those, I think, is within engaging the patient community in some of this. And I don't think John and I both argue they haven't gone far enough, and he can talk about what that's going to look like in the second year. But I think the one big thing between first and second year that's still very much unknown, and is going to be even unknown from the people that are participating in the second year, is what exactly CMS used to determine those prices that they came to from the first year, because we're not going to know that until after the second year, the drugs are decided. And so I think the first year was a very experimental year in many ways, trying to get this right. But I don't know if this year is going to look similar to the subsequent years. I think the following years there's going to be changes, and I wouldn't be surprised if 5 years from now things could be, I wouldn't say very different, because there's obviously restrictions within the legislation, but the way that they go about the process hopefully will be much improved in year 5 than it has been in year 1.
Thanks, Jason. And John, were there any surprises in the first round, or did it go pretty much as everyone expected?
That's a hard question to answer, right? I mean, I think first I'd agree with Jason that, look, this has been a very political process, and my concern about the actual policy that they're using to solve a political solution or a political problem is that it doesn't really help solve the problem of patients paying high out-of-pocket costs, the way that the Part D program was really, unfortunately designed. And I think there have been a lot of efforts thus far that have tried to get at the heart of the matter, which is the way that the plans aren't sharing savings with consumers at the pharmacy counter. And I'm not sure that this program is totally going to solve that problem. But I also don't think that there's been a lot to learn thus far with the information that CMS has put out. And Jason hinted at some of that. We're watching really closely for when CMS puts out what they refer to as the concise justification, or their explanation for the prices that they call the maximum fair price. And I don't think that there's going to be much in there to give manufacturers a sense of what kind of evidence CMS actually used to land where they did. And that's not going to be helpful for folks who are participating in the second round. And of course, we're talking about Part D today. This is eventually going to affect the Part B program, and that's going to inject a whole different set of problems. So I think there's still a lot of questions and uncertainty about this first round. When I think about the second round and I look at the final guidance, I see some small updates, but again, there's a lot of uncertainty. And something that I think really needs more attention, and that is creating a transparent and predictable process so that manufacturers who are getting ready to participate in the next round or subsequent rounds will really understand what kind of evidence that CMS found compelling and was willing to consider. And that's a real important issue if you're engaging with a government that is really becoming an entity responsible for more and more prescription drug spending.
Thanks, John. And John, NPC has published some recent research on the impact, potential impacts of the IRA. Um, can you tell us a little bit about some of the questions you asked and what you found?
Yeah, I think when I think about this program, which I really don't see as a negotiation, we wanted to sort of move past that and better understand what some of the unintended consequences of the law will be, because every law has trade-offs. I think the Part D redesign or the out-of-pocket cap, is a real godsend for patients, and yet what is the cost of that? And we've found over the past year through our research that the IRA may delay launches. It may lead to fewer post-approval research programs and therefore fewer subsequent indications. Changing the incentives for drug development may then lead to less investment in post-approval outcomes research that both providers and guideline developers rely on. And then because of the way some of the incentives and the financial aspects of the program for plans work, I fear that the IRA may actually encourage insurers to restrict access for the drugs that were selected. And therefore, again, it kind of gets back to the, if we're doing all of this for patients, let's first make sure that we don't impact patient access to innovation. So all of this to me adds up that for the first time in my career, I think policy risk is at least as significant as the clinical or regulatory risk of getting a product approved. And that's going to have a real effect on the ability for biotech and pharma companies to reinvest in their R&D. So again, I'd also add that the IRA is just sort of one more cut into an industry that is already providing significant discounts via 340B, commercial rebates, the Medicare drug rebate program, and then there are a lot of other ICER-related pressures that slow the uptake of a new medicine as you launch it. So when you stack all these things together and then add the IRA on top of it, I think all of these cuts are getting us really close to hitting an artery.
John, one of your articles talks about subsequent indications in oncology products. Can you share with the audience, why are subsequent indications important? What do they do? And then what could the potential impact of the IRA be on those indications?
So our first research in this area looked at the small molecule drugs with the highest gross Medicare Part D spending. And you open this webinar by saying high cost drugs. And I remind everyone that it's high spending drugs that they're selecting products for the program for. Subsequent indications or additional uses of a medicine after approval are based on clinical trials that are done on medicines after they've already been approved. And if you started that development program or did that additional research after the drug was approved, on average, those new uses weren't approved until more than 7 years after the drug was first approved. And if you look at the timeline that the Inflation Reduction Act is using for the drug price negotiation program, that's why I believe it's going to significantly affect time to first launch, potentially decrease that post-approval research, and then ultimately impact patient access. So based on the response to that first work, we then took another look with sort of a deeper dive on oncology. And we found when we looked at the 90 or so drugs used in oncology that were approved by the FDA since 2008, we found that nearly 2/3 were later approved for one or more additional indication. And about a quarter of these drugs were approved for their most recent use after the time at which the drug would be eligible for the price setting process through the CMS drug price negotiation program. So again, it concerns me that the message that we're sending to manufacturers is either don't do this additional research to generate these new uses of medicines, or maybe do your research and wait until you have enough uses to then launch your drug so that you can slow the start of that IRA clock, or potentially even do that research outside of the US and make drugs available to patients over there. So there's a lot of nuance to this research, and if that sounds interesting to you, I'd encourage you to either find us on LinkedIn or subscribe to our newsletter at npcnow.org.
Right. Thanks, John.
Jim, can I just add real quick to that? Just
Absolutely.
because I wanted to just, as John well knows, and even though the research was just focused in oncology, I was at there's a summit here in DC, the Breakthrough Summit for the National Organization for Rare Disorders, or NORD. And you're hearing the exact same thing from the rare disease community as well. These types of indications where they're concerned that the innovation that is needed greatly within rare disease, since only 5% of the 10, 11, 12,000 rare diseases have any sort of treatment, they're not going to get it because of these negative incentives that John, has brought up and the research has expounded upon, within the IRA. And so there's a lot of concern, not just from the oncology community, but even the larger kind of rare disease community, where that sort of innovation is greatly needed also.
Thanks, Jason. And staying with you for a moment, can you tell our audience, why is a transparent process important, and then has the process been as transparent as you would like?
Well, I think just to kind of continue what John had mentioned about the need for transparency, I don't think it's been transparent for a lot of us that have been involved or have are stakeholders in the process. It's hard to know how transparent the negotiations themselves were, because that's only between the government and the manufacturer itself. But from all the people that I know that have been kind of involved in conversations, including ourselves with CMS, there's only so much they're willing to reveal. And like John, I am not super confident that when they are required to reveal something in March of next year about how they got to the prices that they came to in round one, that they're not going to share a lot. So one is, I think there's a lot of questions about the transparency to date. And two is, I don't think there's a lot of confidence that they're going to be even more transparent, particularly with the public, and even more specifically with the patient communities who, obviously have a direct stake in what is going on with these prices and, the effects on access to these drugs that they might have, and then future innovation for them in whatever disease area or disease condition they have. So I think transparency is something that we need to continue to call for, more transparency, and not have them limit it. And then when there are times where they're required to actually share with, where they got to the prices, that they actually reveal enough that it can benefit, not just the patients that I just mentioned, but even future manufacturers that are going to be involved in the process in subsequent rounds when the drugs that they produce are going to be part of the negotiation. So I would say there needs to be more. There hasn't been enough, and there probably needs to even be more than even what they're anticipating on providing in the near future.
Thanks.
Yeah, and Jim, Jason makes a really important point there. And again, I just want to underline that this process doesn't allow manufacturers and other stakeholders the opportunity to inform, evaluate, or even predict how this process is going to work. And as a science-based industry that generates a lot of research, I think it's really important to understand what research is going to be valued, and whether or not the agency is going to continue to value that evidence. But while we're talking about transparency, I think the effectuation of this program, or how it's actually going to be implemented at the pharmacy counter, is injecting a new set of angst into the stakeholder community. And there's going to be a really big issue with the lack of transparency in the 340B drug pricing program, and how that impacts the verification of 340B discounts and non-duplication versus the drugs that are being submitted for effectuation in the MFP process. And when you have to spend more money to effectuate a benefit, and then ultimately deduplicate the claims to make sure that you're not paying twice, again, that adds a lot of cost to a program with uncertain benefit.
Thank you. So I'll come back to the impact on patients that you mentioned in just a minute, but the election is coming very soon and is top of people's mind. And could conceivably have an impact on future negotiation rounds and how the IRA develops over time. So, John, you have a background working in an administration. And so can you give us a little bit of insight into the political side of the process and what you think the elections might mean for the future of the IRA?
Yeah, well, I mean, being a federal health official for both teams in the past, I think is what leads me to say that first there's a policy process that everyone needs to participate in, and there's a really big need to continue educating key government officials on how this ecosystem really works. But getting back to politics, I definitely worry that there's a real big opening for politics to get added to the equation. And as I said at the top, what's good for politics isn't always good for policy. This law puts the health secretary and the CMS administrator, who are political appointees, regardless of whether there's a red team or blue team in office, in the middle of this process. And when I just think about the first year, I can't help but notice that MFPs were announced just before recess, while members of Congress were in their district campaigning during election year. So I suspect that some of that is going to continue, but we'll let you be the judge of that. But I want to get back to this bigger political picture about using drug pricing as a way to score political points. Every dollar of what we call drug spending in the United States, out of that dollar, 53 cents goes to someone other than the manufacturer. And I know as a pharmacist that when Americans like my mom talk about prescription drug prices being too high, they're referring to what they're being asked to pay at the pharmacy counter, which again is more a function of the insurance card in your wallet than any pricing benchmark. So helping policymakers and decision makers understand how this messy system works and how it oftentimes doesn't work for patients is a really big part of what we need to do to move from a system that treats drugs as something to extract margin from to something that helps patients get well, stay healthy, and spend less on their healthcare.
Thanks, John. Jason, what are your views on how the elections might impact the negotiation process?
I'll start by saying I don't think we have any idea, because just like we don't have any idea where the election probably is headed. I think that because this was passed in a Biden administration, I think if there was a Harris administration, it would at minimum continue and maybe accelerate in certain ways. I don't think there'd be any pullback. With a potential Trump administration, I think it's anybody's guess. He or the campaign has pulled back on some of his previous, policy ideas around trying to lower drug prices, whether it's, most favored nation status or whether it's international reference pricing. And so, obviously he's always talked about, making the best deals and being the best negotiator. And so maybe he'd want to interject and think, his administration could do better negotiation. So I don't know if we have any idea. I would say, at least in the short term, I don't think there'll be many changes at all. I think it'll probably just continue the way that it has been going, at least in the short term. My concern would also be, are there other things that, might be implemented that, aren't even being talked about now because of the politics around it. But then, when an administration comes in, as John had mentioned, is the policies could be very different. But I would say, for the short term, I don't think there'll be that much change. Now, the one, and John brought this up too, with the political appointees, when you have a new, secretary, a new CMS administrator, they might want to put their own, imprint on how things look, and even within the statute and the regulations around it, there is some flexibility. And so, until we would know who those people are, I think, again, that's an open question of how things could change.
Right. And
Jim, can I just mention one more thing? Maybe you were going to get this too, is in addition to kind of the high level people that John had mentioned, there are also people at the kind of, on boots on the ground level that are doing this work every day, that we know there's been some transition. Some folks have left recently. new folks might be coming in, they're continually hiring folks. And so I think that's still, additional uncertainty to how that could affect the process as well, because like the first round, they have pretty strict timelines for the second round and then subsequent rounds. And so hopefully things won't get rushed or done too quickly without thinking about some of the implications, just because of not only the election, but some of these transitions with staff.
Thank you. And, we're all patients sometimes. And so the patient perspective is always important to everyone. Jason, your organization has advocated for increased patient input into this process. What do you see as the role of patients in the process, and why is it important?
Thanks, Jim. I mean, I think patients and the patient communities for these different disease areas that the drugs treat is critical, for several reasons. One is, around the patient journey and what they experience in these diseases, the preferences they have on outcomes, what they see as, the focus from CMS is on clinical benefit, but there are obviously other benefits as well that need to be considered from the patient perspective, as well as their families and caregivers. And so the only way to know or get that information is actually engaging with the patient community in a thorough manner, and not just with what they've done to date. So far they've only done these patient listening sessions, which I don't know if Jim, you've listened to any of these, but there are plenty of people who speak on those that have no connection to the actual drug or disease condition that was being addressed. I know they've put out new guidance to help improve on that. I still think that is limited, and that they really need more of a systematic patient engagement program to engage these different patient communities. And so you're kind of just reiterating a little bit what John said. It's the patients that are affected, whether it's at the pharmacy counter, whether it's going to be later down the line when it comes to access to these medicines, when even further in the future, when you think about new innovations in diseases that aren't being even addressed yet, it's all affecting the patient. And so because of that, they need to be engaged, and they need to be engaged early on, and they need to be engaged in a systematic manner so that you can get the information that you need, so that when you're coming to the table with the manufacturer and talking about the negotiation and the value, and they're trying to demonstrate the value that their drug provides, that you include that patient information that's so key to determining that value.
Yeah, and Jim, I really want to thank Jason for his leadership on this topic. I think he and his organization and those of people like Randy Rutta and Sue Peshin have made a really strong case for the importance of incorporating more about patient preferences, and for good reason. We did some quantitative research on this topic, and when we analyzed the amount of time that was spent in the first round of listening sessions, we found that on average, there was less than 15 minutes of patient-focused input per session, and that the speaker demographics fell well short of capturing voices of diverse and Medicare-specific patient populations. So our work in this area will continue, and I hope others continue it as well.
And Jim, just to reemphasize a point that John just made around equity, that's another key component that obviously is overlaps with patient engagement. But CMS has its strategic plan and its core principles. Its first one is health equity, and there's really nothing in any the legislation or the regulations or the negotiation around equity and how they're trying to address equity in the process. And so that's another area where I think is really important for them to come out and say, this is how what we're doing to make this more of an equitable process and have underrepresented populations involved.
Thanks. And Jason, of course, we're not aware of the true impact yet because the prices aren't yet being used. They just were announced. But it seems a long way from the negotiations to the person John described, who is thinking about the amount they pay at the pharmacy as what the cost is. Will patients see the benefits of lower costs resulting from these negotiations?
I think that's a really good question, but a hard one to answer. I think most of us would agree that there are other aspects of the the IRA, the Inflation Reduction Act, that address that issue. I don't think that this is one of the main ones that does address that issue. I think the drug price negotiation program is more about bringing down costs down for Medicare. And so I think it's going to be really hard to see, at least initially, what effect that's going to have on what patients actually pay at the counter. So I think that's in my mind, more of a wait and see. What concerns me is some of the unintended consequences that could happen, which we're not even sure, could this happen or not? There's been speculation that manufacturers would increase list prices initially. I think there's probably many people who don't think that would happen, and some of the manufacturers said that wouldn't happen, but obviously that would be an unintended consequences. We've seen recently certain pharmacies saying they're not even sure they're going to have some of these drugs that are on the list as well, and so obviously that would affect access. And so I think your original question, it's really hard to know the direct effect that will have on what the patient is actually seeing at the pharmacy counter and what they're actually paying. But I think there is a fear that some of the unintended consequences will have bad effects on access to some of these drugs. And so that's something that's going to have to obviously be addressed while trying to bring down prices to increase access for patients. Potentially, there are going to be other negative effects to access potentially as well.
Yeah, and Jim, I think there's a lot of really important research that's coming out to underscore those points. I mean, first, like I said, I think the out-of-pocket cap and the cap and smoothing provisions that allow people to spread out their annual a high monthly cost, over the course of a year are going to be really important for patients. But when we step back and look at the combination of the price setting process without clear CMS requirements on the formulary review process, I think the jury's still out on what this is going to mean for patients. We had a publication in JAMA Health Forum at the end of last year that showed for most of these drugs that were selected in the first round, access was really good, and it's actually gotten better. There was very little utilization management on the drugs that were selected. And now there's an IQVIA analysis that shows that 6 of the 10 drugs that were selected already had fixed copays that will either not be affected in changes in price or may potentially increase depending on formulary changes. And here's why that's a big deal. This program changes the financial incentives for Part D plans where we could see where they now have 3-4 times the risk in the catastrophic phase that they once did. It now generates a positive return on investment for utilization management. So could we see some of the drugs that were selected end up on higher tiers or being, subject to sort of step therapy or other utilization management requirements? Could we see higher patient copays and out-of-pocket costs? I'm not entirely sure. And then, about 40% of the patients in Part D treated with the selected drugs already have access to low-income subsidies and are already paying low fixed cost sharing. So they may be unlikely to see lower cost sharing as a result of the price setting process. And I do want to give a shout out to all the non-government leaders out there who are trying to draw attention to some of the things that can help patients through these first few years of redesign. Again, Randy and Sue at the National Health Council and the Alliance for Aging Research have done some really important work to sort of help patients and beneficiaries in Medicare understand how the new cap and smoothing program will actually work. And I recently read a post online from a senior leader at Astellas that was drawing attention to that work and just trying to help raise awareness of the resources that are out there to help patients get through this transition.
Great, thank you. So is it your view that the price negotiation program was conceived as being between manufacturers and CMS, but there wasn't enough work on how does that translate through the health plans, their pharmaceutical benefit managers, pharmacists, and actually what is the impact on the patient?
Absolutely. And again, I mean, like this This was done in a hurry. You know, whether or not you had the votes or not was important, and I think that there's a lot of input that could have guided the legislative process into something that might have led to a different outcome. But I don't think that input was sought as robustly as it could have been.
And I would just add to that, not only was the legislation done in a hurry, but the implementation was pretty quick as well. If we think about even, obviously Part D and much bigger program, obviously, but the legislation passed in 03 and then implementation really had, 06. So obviously some people would say that was rushed, but at least you had a little bit more time. This was, a little bit more than, I mean, what, less than 2 years. And so I think that's why CMS is willing to say, look, we're going to make mistakes. There's going to be changes in other rounds of negotiation, but it's because they didn't really have a lot of time to think about some of the stuff that we brought up today within the time frame that they have for the first round.
Yeah, and Jim, given your important audience, I will also give a shout out to the hardworking men and women at the CMS career team who always do a great job of doing what the politicals ask them to do under incredible timelines. And I think despite some of the consequences of this law, it shouldn't do anything to undermine the respect we have for the people over there that are working so hard.
Yeah, agreed.
Thanks,
Put in a
John.
bind.
I fully agree, having been at CMS, and a lot of our team members are former CMS staffers. So we agree that they work hard and do the best they can with the direction and time they have to do it. Jason, values in the name of the center. So I wanted to ask you a couple of questions about value. So what role does value play in negotiating the price of a drug in this process?
Well, per CMS, it doesn't play a role, though I would argue that they're trying to do that without saying they're trying to do that, and the restrictions that that they're under. When you're trying to take the two aspects in many ways of the value equation of kind of clinical benefit or comparative clinical effectiveness of these medications on one side, and then you're trying to come up with a price to negotiate with, you're actually in an indirect way trying to determine the value of these medications. And from the manufacturer side, they're in the negotiation trying to demonstrate the value. They obviously do, even obviously way before the negotiation, they're doing a lot of health economic research and work to determine the value of all of their medications. And so I think value does play a role. CMS doesn't really want to be in the value business, so they say, and so I think they're reluctant to admit to that, but they're trying to do aspects of determining value without actually saying that. And I think it's going to be really hard to keep those separate as they move forward. They obviously are under certain restrictions, like they're not allowed to do what a normal, health technology assessment or HTA would do in coming up with a, determining based on, qualities or cost per quality or quality adjusted life year, because of they have legislative restrictions around that. But they're trying to, I think, work around that in certain ways. And so I do think, even despite what they say they're actually doing, I do think they are in an indirect way, at the very minimum, trying to determine the value of these drugs. And again, I'll just reiterate from what the manufacturer's perspective, when they're coming to the negotiation, they're trying to actually to demonstrate, look, this is how valuable this drug is. Now, the one, tying it back to an area that we already talked about, what they're not really bringing in, because CMS is not really engaging the patient community, is there's more opportunity, I think, to bring in the value to the patients of their medications as well into this process. And I think that would go even further to helping determine the value of these medications. But I'll finish with this, Jim. I mean, I think that CMS and the government as a whole are very reluctant to be seen as an organization, or the government, the government itself determining, what is the value of these drugs, what should they, what are we willing to pay for them, and to come out and say that. But that's basically what they're doing within the negotiation, or as John mentioned, which is a little bit more accurate, the price setting of what, the government will pay for these within the Medicare population.
Yeah,
It's-
and Jim, no one knows more about the value of a medicine than the scientists that work at the manufacturer that discovered, developed, and commercialized it. And I think that's why we've called on the agency to build a more transparent and predictable process. Because if manufacturers go through the exercise of generating a lot of evidence, especially post-approval evidence, and the agency doesn't value that, it's going to have a really chilling effect on that really important evidence generation. And I'd also say that what doesn't belong in this process at all is any reliance on a cost plus process, or trying to import ex-US prices into the discussion.
Thank you. It does seem like they call this the maximum fair price, and it does seem like the word fair must mean something and may lead to some valuation of we pay more for something that works better than something that maybe doesn't work as well. But I don't know, from your perspective, is CMS shed any light on how they view the word fair? So
It seems like it's fair to them and what they're willing to pay. That's what it seems like, but I haven't heard any other.
And then I wanted to put all this in context. Medicare spends an awful lot of money, and CMS as an agency with all its programs spends even more, like $1 trillion. CMS announced that this saves, $6 billion. How should we think about that to put it in context? John?
I think there's a couple, three, important things to remember when you're talking about economic modeling. I think first, this would be a great question for CBO and CMS, both who put out numbers without necessarily showing all the work that went into it. I'm a little dubious of some of the savings estimates that have been announced thus far. It may be comparing 2022 apples to 2026 oranges. I think there's been a fair amount of only in Washington math that went into paying for the reconciliation bill, and CBO has since come out and revised some of their estimates. So again, when you combine the great deal of uncertainty about the impact of the price setting process, combined with the uncertainty as to what the benefit or the savings of this program will either be to the government or to patients, it raises a lot of questions. But back to something that you said, prescription drugs are a fraction of total Medicare spending. And I get really nervous when I hear people from a political perspective talking about wanting to negotiate the price of more drugs more quickly, and using that to pay for other priorities, whether it's home care or dental or anything else. So again, I'd like to see more of a focus on the value of prescription medicines and helping people avoid more high cost care settings, and the way that they help people get well and stay healthy, as opposed to trying to squeeze more out of drug prices to pay for other things.
Jason, what are your views on the estimates of savings resulting from the drug price negotiation program relative to other Medicare spending?
Similar to John, I think there needs to be a little bit of hesitancy in questioning those estimates and how those are developed and generated. So, but even if you take them at where they are, 6 billion, whether it's 3 or 6, I mean, that, to us, that seems like a lot, but as you rightly note, Jim, within the larger government spend, it's very little. And even within, you just look at Part D spend, it's, less than 5%. And since that's only 10 to 15% of the total Medicare budget, then you're even talking, hundreds of, or tenths of percentages of what you're actually saving. And so I don't think it doesn't seem to be that significant, though I think what people are, who are supportive of the program are hoping that is just the beginning and it'll build to, a much larger number. I think what's more important, again, just reiterating something John said, is, is the program meant to save Medicare money? Yes, I think that's probably the primary. Is it doing a good job of that? Maybe not as well as people would hope, but more importantly, shouldn't it be to actually lower the cost for the actual Medicare beneficiary, the patient themselves? And, when it comes to that, it doesn't seem like this specific program is actually doing that or even will do that. And shouldn't be we more concerned about that? And, obviously I'm going to agree with John about, we should be focusing more on the value that these innovative therapies, these medicines are giving to patients, more than, let's just worry about, cutting prices and saving costs. It's more about the value they're providing, and also doing a better job of determining, longer term value and the costs that could come down because of that as well. I mean, there's plenty of research out there showing that, increasing drug spend, even within Medicare, actually decreases, cost in other areas of Medicare. And wouldn't we want to do that, since that's better for the patients? We'd rather have a patient take a drug and feel better than have to go into the hospital, for some sort of procedure or other sort of service. And so that all comes back to what John mentioned about value. And I think that's what we need to focus on.
Thanks. We largely focused on the drug price negotiation, but Jason, I was wondering, we highlighted a couple of other provisions of the IRA that might have a more direct impact on the patient's pocketbook. Can you go over a couple of those so folks know, like, what should I be paying attention to besides the negotiated prices?
Well, I think John mentioned, I think the two most significant, one is the $2,000 out-of-pocket cap to patients. So, that brings down the current out-of-pocket cap down pretty substantially. I think that's going to be the biggest benefit for patients and helping them to save money. I think, John mentioned also the Part D redesign and some of the smoothing around that, I think, is also going to help patients as well. And probably the system as a whole as well. And so I think those are probably the two most significant aspects that I think will impact patients more directly and will help them when it comes to what they're concerned about. And that's, paying a lot at when they go to purchase their drugs at the pharmacy.
John, and I didn't get a chance to ask you earlier, but I didn't want to miss this. All the negotiation so far has been around Part D drugs that are generally pills. But the Part B, as in boy drugs that are administered by physicians, are coming up next. What are some of the differences that the IRA could cause for these new biologics and physician-administered drugs that weren't issues for the pills, or maybe not as important?
So I think the program as a whole is essentially in many ways rewiring the way that drugs are acquired, paid for, and reimbursed. And we spent a little time talking about the efforts that will go into sort of making pharmacies whole between what the price they acquired the medicine for and what CMS says the MFP should be. And there's a lot of work that's going to go into verifying those claims, making sure that they weren't subject to 340B discounts somewhere else, ensuring that they were actually provided to Medicare beneficiaries. And that's why, Jason said there are some pharmacies that aren't even sure that they're going to be able to offer these medicines to patients. And I think the same has a potential to be true on the Part B side. And we're just starting to do and see the research and hear the concerns of the provider community in terms of how they're going to get access to the maximum fair price via effectuation. I'm concerned about the spillover to the commercial market. One of the ways that the MFP will be incorporated into ASP will also change the way that not just Medicare, but many commercial contracts reimburse medicines as well. So making sure that that providers aren't underwater or adequately compensated for seeing patients is going to be important. I think there are also some concerns about the differences between how this will affect community-owned outpatient practices, especially in oncology and immunology, et cetera, versus those that are owned by a hospital, especially a 340B eligible safety net or DISH hospital. They get a choice between the acquiring at the 340B price and being reimbursed, at MFP +6, and that's a choice that community-owned practices don't have. So again, I think there's going to be a lot of uncertainty in the Part B program as we begin to assess the spillover to the provider community. And I can think of a lot of friends who would love to join you in the forum on a future webinar on that topic.
Thank you, John. Jason, we've run out of time, but I wanted to know if you had a final thought to leave the audience with from your remarks today.
Yeah, thanks, Jim. And thanks again for the opportunity to join you again. I would just, want to emphasize to the audience to continue to advocate for policy changes that are needed within this program, particularly for the patient, and to focus on getting the patient more involved, the patient community engaged, making sure that improvements to the program, could be made so that a lot of the unintended consequences that were mentioned today, hopefully we can minimize those and have them not happen, and to really focus on what is the most important aspect of this program to help the patient and their family and their caregivers, and try to emphasize those parts of the program that would do that versus other aspects of the program that we mentioned today. And that includes everything we talked about around transparency and patient engagement and everything like that. But I think one thing that maybe we didn't mention is CMS has been very receptive to all the things that we've talked about. We don't really know if they're actually making changes or implementing them, but I think as more and more voices continue to focus on the things that we talked about, I think CMS, they're willing to make some of these changes, and hopefully the more people that talk to them about it, it'll be more likely that those changes are implemented and the program will be improved.
Thanks. And John, what's the one thing you'd like our audience to remember from our conversation today?
The most important thing to remember today is that good policy begins with good research. And we've talked a lot about unintended consequences. We've talked a lot about what the benefit looks like today. We're going to continue to do research that looks at what's actually happening in the program and trying to get out ahead of some of these unintended consequences and measuring how they're impacting patients. So I'm a big fan of applied policy and your insights. Like Annie, I'm going to go ahead and paste the link in the chat to sign up for our NPC This Week newsletter. And we really look forward to staying in touch with the forum and this important community to continue to share our research and what we think that means for health policy.
Well, that brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, John O'Brien and Jason Spangler, for sharing your insights about the ongoing CMS negotiation to reduce drug prices. And thank you to the Applied Policy staff members who work hard each month to present this valuable discussion, especially Annie and Allison. We hope you'll join us for our next forum in November, when we'll take an in-depth look at the current and future approach to treating and preventing diabetes. Before I close, we just sent a message in the chat with links to subscribe to our monthly newsletter and view our Northern Virginia Health Policy Forum website. We also chatted a link to sign up for the NPC newsletter, and we hope you will subscribe to those to learn more about the forces shaping current healthcare policy. Thank you for being here, and enjoy the rest of your day.